Welcome to episode 6 of RTMatters, where candid conversations take place about what matters most to respiratory therapists. I'm Patrick Dunne, your host, and I'm delighted to welcome you to our podcast. And I'm really excited about this episode, Evaluating Clinical Evidence in Respiratory Care. And the reason we feel this is important to our members is because there's an awful lot of recent posting to the AARC Connect about this very important topic. You know, what is evidence? How much evidence do I have? What do I do if I can't find evidence for the procedures that we do that are very time consuming? And to have a guest today that can really drill down that, I'm just delighted. I'd like to introduce you to our special guest, Dr. Robert Joyner. Dr. Joyner has his doctorate in physiology, but he's also a registered respiratory therapist, and he has the adult critical care specialty exam. He is also a fellow of the AARC. And since 2019, he's been the director of TidalHealth's Richard A. Henson Research Institute at the TidalHealth Peninsula Regional Health System located in Salisbury, Maryland. And that is a major health system serving the entire eastern shore of Maryland. Welcome to RTMatters, Bob. We're delighted to have you.
Thank you for having me.
Well, actually, before we start, one of the features of RTMatters is to have our guests talk about how they got into respiratory therapy. So my first question is, would you share with our listeners where you were personally in your life when you first decided to become a respiratory therapist?
So I think I got into respiratory care very similar to the way in which the older group did. Maybe you, me, and other people.
I resemble that, by the way.
As what you don't hear these days as an on-the-job trainee or an OJT. I was in college and had spent 2 years in college. I was a chemistry major headed toward medical school. At least that's what I thought. And as with anybody, I needed to earn some money. This was way back in the middle 1980s. Needed to earn a little bit of money. And so there was a job in the newspaper for a certified respiratory therapy technician, or a CRTT. And I am the kind of person that certification, what does that really mean? So I applied for the job. And at the time in the state of Maryland, there was no licensure required, wasn't even in the state. And I met with the department manager, and I think I was about 19 at the time. And he said, well, you got good grades and you finished that anatomy and physiology. Why don't we give this a try? And
absolutely,
I was hired within a day as what they called a respiratory therapist. I had no background other than I knew what breathing was. And my first task within a good 10 minutes of the job was to attend a code.
Yes.
And they got me to do chest compressions on my first code. And I will tell you that I nearly quit. It's about the end of my job.
Well, you didn't quit because later you actually went on to obtain your associate degree in respiratory care in 1990. And then you continued, a year later, you got your baccalaureate degree in respiratory therapy. That didn't stop you. You returned to college again, and in 1998, you earned your doctorate in physiology at Dartmouth, so you actually probably could have become a physician. What prompted you to continue your education?
So one of the things that's addition to what you're saying is when I left my baccalaureate program, I had already been practicing for a couple of years. So I traveled as a respiratory therapist. I went to Tulane in New Orleans and got to experience a hurricane way back in 1991. I worked in Boston. I worked in a number of different places. And very quickly, I knew that I wanted to go back to school. The question really was, did I continue to want to be a physician or did I want to be a scientist? And even back then, I recognized the limitation of medicine, which I still recognize today, and wanted to be part of creating knowledge. And so that's why I went to a doctoral program. And to be fair, I did go to medical school. I graduated from Dartmouth Medical School from their physiology department. I studied pulmonary hypertension. And just as a sort of interesting sideline, one of my claims to fame back then was that I could put a PA catheter in a 270-gram rat. And yes, that's possible.
That's right. Well, you really indeed, you pursued it. You sound like you got into respiratory therapy because it found you, and then you decided this was a good career opportunity if you played your cards right, which you obviously did.
Working with patients that are short of breath, working with those patients became an immediate passion of mine. Being able to relieve that agony in that person became something that I've pretty much devoted my life to.
Yeah, even with the limited resources we had back in that time, I remember distinctly my first go-round was washing the reusable oxygen canopy tents and then doing IPPB treatments and duly rinsing out the nebulizer and not so much the...
Sure, and exchanging out the ice on the crew tents, right?
That's right, that's right. We'll have another show later on for our new listeners to describe exactly what those items were. Now, let me ask you also, in your career, I noticed you joined both the AARC and the Maryland, D.C. Society, getting involved as a volunteer on top of everything else you're doing. What prompted you to volunteer your time on when you had so many other commitments going on in your life at that time? And you continue to do so today, I might add.
Yeah, honestly, I probably am going to give kudos to my mom in that what she had always told me is, I don't care what you do, just be the best at it. And it seemed to me that interacting with individuals that are smarter than me, which I still love to do today, I agree with that concept of if you're the smartest one in the room, you're probably in the wrong room. Mm-hmm. And so it's an opportunity when you volunteer like that to meet people, to interact with them, it's very fulfilling work to volunteer in that way.
Yeah, well, it came back to help you because another noteworthy professional activity, probably up there with the top one, was being appointed to a trustee at the NBRC. And eventually, in 2016, you were elected to serve a 2-year term as president of the NBRC. How did your prior voluntary activities at the local and the state level prepare you for the huge responsibility of leading our profession as internationally recognized credentialing organization?
You know, interacting with the people that are at the NBRC, and I get it, they develop exams, and because they develop exams, they're pretty much targets for people who aren't finding it easy to pass exams. And so that's what happens. But what people don't commonly recognize is the amount of science behind the development of the exams. It attracted me. I got to meet really sort of world-renowned researchers and clinicians that were there, and they embraced me. They taught me, and they have done that ever since. And I will forever have a very warm spot in my heart for the NBRC. I'm still doing some work for them, but it will always be one of the pinnacle highlights of my career, being able to travel around the country and talk about respiratory care and get people to understand what we do as respiratory therapists, but also get people to understand really the accomplishment that respiratory therapists have because of passing those credentialing exams. I have frequent conversations with nurses or pharmacists or otherwise when I explain what it takes to become a registered respiratory therapist. And they're amazed at how difficult that is. And it is difficult, and it's an accomplishment. So,
well, congratulations on a very impressive journey, and thank you for keeping our esteemed credentialing system to the highest standards. I have a little story. When I was first appointed a trustee way back in the 70s after I finished graduate school, and we were moving to the criterion reference exam with job analysis, which of course is the foundation today. And I remember going to my first exam, and I lugged all my textbooks to Kansas City. And I walk into the room, and my mentor at that time was Andy Block, who was chair of the written exam committee. And I looked around, and I said, Andy, I'm dealing with textbooks. He said, we don't need textbooks. I said, what happens if we have a question where nobody... And he pointed, see that fellow over there? It was Dr. Helmholtz, Dr. Fred Helmholtz. He says, that's all the textbook we need. And sure enough, probably about a half an hour into the meeting, a question came up, and nobody has, Fred, what are you Well, in 1929, so-and-so, I mean, it was just an amazing insight. And I totally agree with the fact that you rub elbows with some of the greatest scientists in the world, whether they're therapists, physicians, anesthesiologists, physiologists. And I just really appreciate the fact that you continued on and helped the organization maintain its superiority. And it's, now I should recognize for those new to our listening, that is the standard exam for all the licensing acts across the state of the United States. So it really has been given a worldwide echo.
Absolutely. My, just to sort of name drop a couple of people. So Rob Shaw is an example of somebody who's taught me more about statistics than any graduate program ever could. So he's one of the people.
And he's also a registered respiratory therapist.
He's a registered respiratory therapist. And then one of the mentors that I had is Dr. Bob Balk, who's now working toward retirement. But he is a person who helped invent the term systemic inflammatory response syndrome. Mm-hmm. And I remain in awe of being able to, one, just be in a room with these people and having conversations, and two, they treat me like a colleague. Yeah. And you know, I probably deserve being a colleague, but the other thing is that I will always remain in awe of these people who accomplish so much in their lives.
That's a great organization.
Dedicate themselves to respiratory care.
It certainly does raise the level in terms of what the expectation is in terms of how the exams are prepared and how the validity and the legal aspects of it are maintained. Well, let's get on to the focus of this episode, where I know you also have an awful lot of strong opinions and practice application. Evaluating clinical evidence in respiratory care. First of all, why should respiratory therapists base how they practice, regardless of the care setting, on strong clinical evidence?
Well, I think the answer to that question is that every respiratory therapist I've ever met wants to do the right thing. I think every respiratory therapist I've ever met also recognizes that there's a limitation in the data, meaning that we don't have all of the clear answers. What I teach people is that you have to look for the preponderance of the evidence. So what is it that the evidence is pointing you to? And once you've reached that, and once you have an understanding of that, you do have to make decisions. And one other piece to this is the importance and responsibility of respiratory therapists, because we do provide guidance to the physicians and other decision makers that are working with our patients, and they listen to us.
And one of the points I made, I still continue to make it, is that we're not prescribers, but we're very, very good persuaders, especially when we present high-level evidence to the prescribers and mid-level prescribers. You also touched on something else I think you're mentioning, and I'm going to mention it for you, critical thinking, in terms of what you use to determine what is a preponderance of evidence.
Well, I'm going to go back to the idea that it's difficult to become a respiratory therapist, and that's on purpose in regards to what the amount of influence that we have on those providers that you were talking about. Being able to critically think through the evidence, and whether it's reading articles, attending conferences, wherever you're getting your evidence from, and being able to put that back together so that when you're trying to get something done with your patient, you know, you can articulate it in a way that the physicians or other providers are going to want that so they can make their decisions. Mm-hmm.
Yeah, I think, like I said, we're great persuaders, but you have to have the evidence, and it has to be free-flowing. You can't just hedge around it. So critical thinking allows you to get there. Speaking of evidence of efficacy, we often hear that since physicians continue to order a particular therapy, for example, the old saying, albuterol, Q4 till out the door, they pretty much do that because that's how they learned when they were in their training, and their mentors told them that albuterol never hurt anybody, but it doesn't necessarily have to stop working. But at the same time, I want my patients to be seen. And I know that you're going to do that if I order those treatments, even though the patient is no longer an extremist. What can we do? Have you ever experienced that, I guess, physicians saying, I just want you guys to see my patients because I know they'll be seen if I order it?
Oh, sure. And I think that's actually an opportunity to change the profession, or at least the way in which we practice a little bit. I think there is some truth. I had a physician mentor a long time ago who used to order chest BT on all of his patients. And literally, we would ask, why do you want chest PT on this patient that doesn't need chest PT? And he goes, because I want you to go see them. And I would always say, isn't there a better way to do this? So isn't there something that can be done that would allow us to see your patient, but not necessarily frustrate us by the orders that you're giving? So the albuterol till you hit the door, it's a medication, just like oxygen's a medication. There's got to be a better way. And so I advocate for those discussions and making sure that, one, the patient's receiving what they need to receive from us, and two, doing it in a way that makes us feel like we're part of a team and not just being used in regards to that.
And I can be complimented by the fact that the physicians have enough confidence and respect in us to see their patients when there is, at this time, even today, a shortage that's hitting all of the healthcare systems around the country. What about background? One of the things that we hear a lot of is that if the physicians would just write a respiratory therapy consult, where we'd evaluate the patient or assess the patient, determining the appropriate treatment, then administer, then evaluate, and then adjust or titrate. What has been your experience in physicians being receptive to these types of orders rather than just prescribing everything, which raises a patient safety issue because, like you mentioned, albuterol is a medication. And if we miss a treatment, technically that's a medication error. And if we're too busy because we're understaffed and we can't get that 12 o'clock treatment, it creates a whole new problem for us. So mention these physicians wanting us to see their patients because of the staffing shortages and the fact that they're in respiratory distress. In your clinical experience, can the implementation of evidence-based, patient-centered, and RD-directed protocols or care pathways reduce the incidence of low-value respiratory care? In other words, physicians ordering therapy that provides little or no clinical benefit.
So I absolutely do believe that that's true, but I also believe that we work within the side of an administrative system. We need respiratory therapists to serve on those important committees that are both inside of the hospital, but also broader than that. So you asked me a few minutes ago in regards to why I volunteered so much. Being part of having a voice and being part of the decision-making system is something that we need more respiratory therapists to be involved with. And so potentially you're talking about hospitals that may not have access to things like respiratory assessment or with the other terms that are used for that. But that's actually sort of, at least in my view, on the respiratory therapy department to bring that to the right committees inside of the institution and carry that out. I have always learned that it does not help just to be mad about the way things are, that you have to be part of the solution.
That's right. Absolutely. The problem, of course, is that was alluded to before is that prior to the DRGs and value-based care, our productivity was based upon how many treatments were ordered, how many we delivered, how many we did not give for whatever reason. And that's a metric that no longer is relative because of value-based care. So we're kind of stuck in a time warp here. And like you say, you get involved with the hospital hierarchy and show what you can bring to try and improve the quality of care and get away from low-value care to high-value care.
You know, one of the things that I think we're both old enough, sorry about that, but we're probably both old enough to know that, you know, the utilization of IPPB for COPD back in the late 1970s nearly brought respiratory care to its knees, right? Because people figured out that it wasn't doing anything. We don't ever need to be put in that position again. If there's low value or unnecessary care, we need to be able to point it out, and we need to serve on the committees that allow us to help make those decisions.
And the nice thing about it is, as we're going to find out, there's a lot of evidence out there of substitute or alternative therapies that are just, if not more effective, but yet they kind of go in the face of counting procedures. It's a different opposite. Now, let me ask you, you just mentioned lack of evidence, and it's kind of really a big challenge. Let's take a look at what we now know is the hierarchy of clinical evidence that our listeners should be familiar with. Let's start at the bottom, and not necessarily the bottom, but the weakest link, which is expert opinion. And for years, that's the dominant source. We've always done it this way. It's worked. Let's continue to do it. Is there any use for this level of evidence?
Sure, there's use for it. I can tell you in my own department, it's almost comical now, although they understand why I say it. I say every time that you are presenting something to me and you start with "I think," that you don't know enough. You have to start with sort of the evidence that's available, and then when you get to the preponderance of evidence, when you understand that, you say what's next, and that's the part where you're allowed to say I think we should proceed in this way. But it shouldn't be the basis of what you do. The basis of what you do, that sort of baseline, needs to be all of the stuff that you've learned across your educational career, but also what you continue to be as a lifelong learner.
Now, we're moving up the hierarchy. The next level of evidence, if you go to the literature, is what we call in vitro bench studies, essentially to establish proof of concept. And people argue, well, this informs clinical decision-making. However, I don't think that's as high a level of evidence as we'd like to think if it's just a bench study.
Well, I think that bench studies are necessary. I think that there's a reason to carry out sort of equipment comparisons or having some understanding of what equipment can do. The quintessential one for respiratory therapists is ventilator testing, understanding things like triggering and response times and things like that. There are reasons to know that. I think that provides valuable evidence. Does it tell us exactly what we're going to do on the patient? No. But does it feed into what we're doing so that we have some understanding? Yes. I think it's very important to do.
But it's not going to be the sole determinant. It's like a hierarchy. You mentioned when we were discussing earlier that you had a little episode with the late Bob Kaczmarek, one of our true heroes. Why don't you share that with our listeners? Because I found it rather humorous myself.
So, as I moved through my career, Bob became a good friend of mine, and I miss him dearly. He was a confidant and somebody that I could call on in regards to when I wanted to make my own decisions and what he thought. So the way I met him, had just come to Salisbury University and performing my first research project there, and figured I'd do something that I knew something about. And that is doing flow by on a 7200, if you know what I'm talking about. So flow triggering on a 7200. So I had students actually helping me with the research, and they determined that the pressure triggering was more sensitive than the flow triggering. And I told them they were doing it wrong. To make a long story short, they proceeded to do it. I finally did it myself, and I found out that pressure triggering was more sensitive than flow triggering on the 7200, at least the version I was using. And it was my first presentation at the American Thoracic Society, and Bob came to meet me. I didn't know him. He came to meet me and he said, "This is fantastic." And I said, because it was a bench study, he said, "This is fantastic." And I said, "Well, good. Thank you very much." And he goes, "It's what I showed 5 years ago in a patient." So what I take away from that was this. I take away from the idea that it was de novo knowledge for me. I learned something. Yeah. But I really needed to read more.
Yeah, Bob was like that. He always had a little bit of truth behind what his point was. But, this is a good time to take a few minutes and let you tell our listeners a little about the Richard A. Henson Research Institute, where you've been, like I mentioned earlier, since 2019. You served as director, and obviously your experience with your other colleagues, including Bob, has a lot to do with that. Tell us about what you do in that position right now.
So you should know I spent 21 years at Salisbury University as a faculty member there. I did a number of research projects there, including students and other faculty, and also helped develop the College of Health and Human Services. And all along the way, I was the director of the respiratory therapy program. In 2019, TidalHealth, which I'd worked at as a respiratory therapist for a long time, asked me if I would ever leave the university. And I said, quite honestly, they're crazy. I'm 21 years in. Why would I leave the university? And they said, "Can we tell you what the title of the job is?" And I said, "Sure." And they said, "The director of research." if you know much about those jobs, director of research, especially on the Eastern Shore, you realize, at least on the Eastern Shore of Maryland, that's the only job that it's going to be. There's not going to be another one. We're not big enough for that. And so I moved. The Richard A. Henson Research Institute was endowed by Richard A. Henson Foundation in 2017. And that allows me to conduct or support research in the institution that I wouldn't otherwise be able to do. We're working on an endowment. We currently have about 50 clinical trials running. We do everything from cancer to cardiac. We have investigator-initiated studies, which are the ones that we develop internally. And we support the graduate medical education with all of the residents. Mm-hmm. I am proud, and I exclaim it every time I can, that I am a respiratory therapist. I do have a significant education behind me, but I am a respiratory therapist true and true. Uh-huh. And I want people to know what respiratory therapists can do. So if anybody thinks I've left that behind because I'm a clinical researcher, I promise you I have not.
Are there students at Salisbury or staff at any part of TidalHealth involved in some of your research studies?
So they are. Actually, I had a respiratory student in a course that I teach called RIME, which means Research is Medical Education, and I teach systematic review, and he got to participate with medical students and residents with that. And I also have a relationship with the math department because I help the statistics students understand that, and a relationship with the biology department. To be quite fair, I have a real sort of soft spot in my heart for young rising students. I'm hoping that I made a difference in that respiratory therapy student's life to open him up to things that maybe he had never seen before. Because I'm also a believer that if you can't dream it, you can't do it. Mm-hmm. And so I try and expose them as much as I can.
Yeah, there's no question the research is so important today, and we'll talk more about that in terms of AI in a bit. Now, moving up the hierarchy, one of the next things we hear about are these retrospective cohort studies where they go back and look at data and try and draw some conclusions. There's advantages and disadvantages of this type of research. What's your take on that?
So it's a start, right? What I'm working with here in the Research Institute is I have people do systematic reviews first so that they can understand what the current data is. Then I have them develop a question that's related to that retrospective data can inform. And the step after that is actually interventional clinical trial, right? So retrospective data helps you develop an answerable question. And so I will also tell you that getting good at understanding your electronic medical record and being able to extract data from that's a challenge all by itself.
Mm-hmm. Yes, I like the fact that it's retrospective, that you're just basically looking at see what happened and see if that can kind of give you an idea what we should be looking at to see if we can do it better. So it is an important part of the hierarchy, but it's not up there. Well, let's moving up to the top of the hierarchy. Let's talk about this clinical evidence that our RT listeners should be familiar with. That's my bad. We should talk more about randomized controlled clinical studies. The top of the hierarchy, commonly known as RCTs, randomly controlled clinical trials. What are the characteristics of these studies that gives it so much power in terms of informing clinical decisions?
So you asked me a minute ago in regards to evidence that's opinion based, right? How strong is that evidence? How should be incorporating that? And I can tell you that it's difficult sometimes to remove bias. Bias is inherent to us, meaning that if we see something work one time, we believe it's going to work again. What randomized controlled trials are attempting to do is to eliminate that bias. And so you have a group that receives a treatment and you have a group that is a control group. And it's randomized, which means that you don't know which one's receiving control and which one's receiving the intervention. So it removes the bias. And that allows you to understand whether or not there actually is something that's changing. And so It is at the top of the heap, but there is one higher.
Sure. Yeah, we'll get to that in a moment.
Okay.
It's interesting that you mentioned that bias because I was retorting a clinical study for a pharmacology firm that supplied a study to the FDA for approval. And they did exactly what you just said. It was proactive. It was basically taking the patients as they were and putting them into the investigative drug and then the control. And people had COPD, and they had current smokers in both groups. And people said, well, that's not going to work. And I said, well, if you remove those from each group, you're showing a bias. So you really have to understand you need to take people into the study who have the characteristics that you're looking for. So your point is well taken. Bias can really sneak its way in, and that's the whole purpose of randomized clinical trials.
So one of the important things with that in regards to one, it's been many years and I keep learning about bias. And so people should understand there's many sources of bias and eliminating that can be tough. Mm-hmm. But what I wanted to say was that when you do a randomized control trial, you have to make sure you're working with a single population. You just said COPD that are still smoking. You have to do that. You have to make sure you're working with the same one so that you know
exactly
the change is real.
Yeah. Now, let me ask you mentioned something about the reader having used critical thinking. Just to be clear, we're talking about studies that are going to be published in reputable peer-reviewed journals. And I've heard something about the kind of predatory journals. Would you tell us how our listeners can separate the two predatory journals for proper peer review?
So I can tell you probably 5-10 times a day, I get requests from journals that are asking me to publish in their journal. The terminology of predatory journals is this idea that journals could potentially just want to be making money. And I can tell you that publishing in a journal could be free, and it can cost $5,000 or $6,000. You want to make sure that you're publishing in something where one, your information will be seen, and two, you're not just being taken advantage of. Because quite honestly, there are journals out there that will publish your information just because they make money. But yeah, I want to say that, but I also want to say something else. The peer review process has taken a beating over the past since COVID, right? Mm-hmm. And what peer review provides to the person that submitted it, is access to researchers who will review their data, their information, and then give feedback. People should embrace that. And it's not perfect, and it is the best that we can do right this second. Mm-hmm. We don't have a better solution for that. And so that leads back to what you asked me just a second ago in regards to critical thinking, how to work through it. That process in itself allows you the opportunity to critically think what people are asking you questions about. And it should be embraced, not suggested that there's something less than honorable about it.
Yeah, no question. I noticed one of the things that for my critical thinking, when I look at a journal, I always look at the dates at the bottom of the front page. Date it was submitted, and then the date it was accepted. And the distance between those two dates indicates that the feedback was sent back to the authors, and they took it in good faith, which I always did when I was publishing. And it's just a really nice little way to ensure that what you're seeing is really true science, which is, of course, what you were saying.
And if you've ever interacted with a reviewer before, then you know the frustration of that. But it's a fair trial.
Yeah, but I mean, it's another one of those things that I didn't think about, and it's a good point. Now, to the highest level of the hierarchy, a systematic review and meta-analysis of multiple high-quality randomized controlled trials. Why are these studies so good, and how does the Cochrane database, what guardrails do they have in terms of what articles they select for their analysis?
So there's a process. It's called the PRISMA process in regards to working through systematic review and meta-analysis. And that PRISMA process, again, is doing its best to eliminate or at least mitigate the bias that's available. Your listeners may be very attuned to reading journals and recognizing that there is something called publication bias. People get published and potentially there's some bias that's associated even with good publications. The way to mitigate that is you take multiple randomized controlled trials that are aimed at somewhat similar topics. You put them together and you carry out the statistics that associates with them, and you can understand what the preponderance of evidence provides. Mm-hmm. The challenge with them is that not everything has a randomized controlled trial associated with it. And so you're still going to work with the idea that you're critically thinking about all of the evidence that's available, and you're still going to have to make a decision. And as a respiratory therapist, it's so important.
That's right. One of the points that I got is to your point, and that is I look at the Cochrane reviews for incentive spirometry, and you can see a lot of the articles that are out there, 80% of them aren't selected. And the reason is there's flaws in the methodology. And the most common flaw is they don't have any information about how the device was monitored during its use, which obviously creates a whole list of unknowns. And so the conclusion is the evidence does not support the routine use of incentive spirometry alone. And people get so upset. I see it in my hospital everywhere. It's on every post-op patient's bed. And it's a talk for another area, that's for sure, about what we can do to take that away, because there is some value in terms of using it properly. Something else I'm seeing is called a scoping review. How does that differ from the Cochrane meta-analysis, a scoping review?
So a Cochrane meta-analysis is, again, sort of related to this idea of what the preponderance of all of the evidence that's available on a particular topic, and understanding the magnitude of the evidence that's there and the quality of it. A scoping review is really sort of talking about when you initially have an idea and you have some inkling of what your question is going to be. What generally speaking is the what's been published about a topic. And a scoping review is sort of really, it's not quite as standardized as a systematic review, but it does get you to a point where you can understand something about the topic and what's available in peer-reviewed journals. It's a good way to start.
That's exactly right. You know, you got to start someplace. And like you say, it's all about where am I going to go next? One of the points about statistical analysis that confuses a lot of therapists is this p-value. It's always reported at the results of a study. Real quickly, what is p-value and how can you best assess a p-value in terms of what is more robust, saying that the intervention worked versus less robust, where there is probably just chance at work?
So one thing that people should start with is that p-value is chosen. It's an arbitrary number, and we commonly see that it's chosen to be p less than 0.05, right? That's usually where we start, which means that there's a 1 in 20 chance of what you're finding is true, right? Mm-hmm. You could make it more stringent. You could make it less than 0.01. You could make it less than 0.001. You can make those choices. But it's important to know that the sort of scientific society has decided that 0.05 usually is what they're going to choose as a level of significance. And it is some sort of predictive value. And for those who are hardcore statisticians, I'm probably using words that they wouldn't like, but it allows you to understand whether or not something's predicted to be true or predicted to be significantly different. Mm-hmm. But you have to be wary of it because it's not the only statistic that you should be paying attention to. There's many others, odds ratios, and what I would recommend to readers or listeners to this podcast is when you're reading journals, pull out the statistics and see what they did. And then if you understand it, great. if you're like the rest of us and we don't understand exactly what they did, then contact a statistician or someone else that's done this before and ask them how this works. You'll only have to do that a couple of times. Like I will promise you that in regards to the healthcare related research that we're doing, it is repetitive in regards to the stats that they're using. And so once you get your hands around those things that are repetitively used, it becomes easier.
Yeah. And I think your point earlier about having the evidence in a way that our prescriber colleagues, physicians and mid-level prescribers accept that we have to really be able to talk about the strength of the article that we're citing or the evidence that we're presenting. Otherwise, we're not speaking the same language. And that's another challenge. And I appreciate your point. Go talk to someone who can help you explain the statistics. After a couple of times, you're going to know how to do that.
Yeah, there's a couple of different ways to grade evidence, but one that respiratory therapists may have access to, and it may be more familiar to them, are the articles that are related to ACLS. The American Heart Association in the ACLS publications have a very good way of evaluating evidence, and it's described really well. So
good start. Go ahead. Well, we've had a great introductory discussion to hopefully get our listeners feel more comfortable when evaluating clinical evidence. But now I'd like your thoughts, and you've skirted around this earlier on, why a lot of RTs, excluding yourself and your one student, shy away from getting involved in clinical research. I mean, it's obviously so important for our patients, and they sure do benefit, but a lot of therapists just throw their hands up and say, that's not for me. What's your experience? What's the big pushback?
So I think that one of the things that research requires is continuous learning. And that in itself, saying it is not bad. It's not tough, right? But I will tell you that learning, physical active learning, is a bit like exercising. And when you first start doing it, you exercise, you're sore the next day. And the reality is you don't want to do it again. So if a person's experience in school, and we already talked about the idea that it's tough to become a respiratory therapist, is that their memory is that wasn't a good experience for them, then this continuous learning that's required is, for the first time, is probably not something they want to jump into. Yeah. But I will tell you, and I'll tell all of your listeners, it's very gratifying in regards to learning something new. And I promise you, once you get into that mode, it is something that becomes easier to embrace. You just have to get through it a couple of times.
I think it's one of the points that you mentioned, pervasive mindset, and that's really something that means the mind shift has to take place to realize that this is a learning experience, and yes, it's new, but you're growing new brain cells, you're getting smarter, you're really improving your career options. So there's no question, and especially today. Now, we finished up here. I have one final question. And I'd like you to put on your clinical hat, which I know you never took off. But as a practicing respiratory therapist, what questions would you have if and when an AI agent is being considered for your department?
So I think it's fair that I have to tell you my background. I have some training in AI, and I also serve on the AI committee for the hospital, the committee that's evaluating AI to be put into clinical service. What I think you need to know is, I think you need to know what the implications are in regards to the AI. So, for example, usually AIs are, at least the AI that I've been evaluating, are related to things like imaging. So can it find something, right? And you have to know that AI is going to be built to find more things than there are, as opposed to missing something, because missing something can be devastating, right? Mm-hmm. So there's work associated with it. So let's say that you had AI that was finding patient ventilator interaction, right? That was reviewing that, and it wanted to identify when there was desynchrony. then what you're going to find is that it's going to identify dysynchrony more often than when the synchrony is actually happening. So I encourage your listeners to think about the workload that AI creates as opposed to the hope that AI would reduce their workload, because I'm not sure it's there yet.
Mm-hmm. Well, I agree. I think the AI is a complement. And my observation, a lot of therapists, especially bedside therapists, are nervous it's going to take my job away managing that ventilator, autonomous ventilators. And I have no confidence in autonomous 18-wheelers barreling down the highway with no driver. I don't want a ventilator without human oversight. And as you pointed out, we're the experts to provide that oversight to make sure that the AI part of it is not what they call hallucinating. That's the term that's used for the mistakes AI scope will make.
Utilizing AI requires an expert, meaning that you have to know when the AI is telling you something wrong. Mm-hmm. It is not true that AI is always correct. It's not true. And it's also not true that AI is not useful. It is useful.
Oh, yes.
But it's not always correct.
Yeah, it can generate so much more data in such a fraction of a time, but we have to make sure it's legitimate data because it's searching the entire World Wide Web. And as we all know, the first question, anything on the web, is it true? Is it really truthfully and factually sound versus the alternative to that? Yeah. That's where that critical thinking.
I think that potentially one of the things that's important here is to know that I believe that AI is going to allow us to make decisions faster. And I think that could be important to patient care. But that as far as I can tell, and I'm immersed in AI, I don't think AI, at least in my lifetime, is going to take over somebody else's job. That's not if they actually want to perform good clinical care.
Well, that brings us to the end of this episode of RT Matters. And Bob, I want to thank you so much for taking time from your busy schedule to join us today. And you actually just lit something up in my brain about maybe we'll get together again and talk a little bit more about AI and how therapists at the bedside can be prepared for that and get a little better handle on it, not be afraid of it, because we don't want anybody to be called a Luddite, which is, in today's term, you don't like new technology. And that's the worst term to have.
I've had an absolutely wonderful time, and I appreciate you asking me, and I would come back anytime.
That's great, Bob. All right. Well, remember, your listeners, we want to hear from you about what you liked and what we can do better to make RT Matters work for you. And you can also request any additional information from any episode, including this one. Simply log on to our website, rtmatters.com, with your tablet, laptop, or desktop, and then click on the feedback item located in the top left side of the masthead. Now, in the meantime, until we meet again, go out and be the best possible respiratory therapist you can be, because our patients deserve nothing less. And as a highly trained in a very difficult profession, as we've heard, and you're a licensed healthcare professional, we expect nothing less from you, nor do our patients. And after your shift, this is my military training kicking in, think about the next shift coming on. So always leave your workplace equal to, or sad to say in some cases, better than you found it when you came on. Make it a clean, professional, and complete handoff. So until next time, be kind to yourself and to others, and remember, RTs do indeed matter. Take care, be safe, and we look forward to having you back real soon.